Hello, everybody. My name is Chris Wilson. I'm the Vice President for Advocacy and Advocacy Communications at the National Patient Advocate Foundation. And I'm so glad that you all had the opportunity to hear the stories that Alma and Freddie and Chad were able to share with us. And now we're actually going to have more of an opportunity to carry the themes that they've talked about, the ideas that they presented, the work that they're doing forward in a panel discussion. When we started this, we really wanted to make sure that we stayed true to our purpose of elevating people's voices and really hearing that. And we thought it would be good to find some people. We didn't want to just focus there. We know there are a lot of problems in rural areas, and we're not ignoring those. We certainly need to acknowledge them, and we're going to talk some about that as we move forward. But we also knew that there were people in communities all over the country who are passionate, who are determined, who bring joy and hope to the communities they work with, and who are very resilient. And Alma and really referenced that specifically. And we thought it would be really interesting to hear some of those stories. And then we thought, well, wait a minute, instead of compressing them into like a 2-minute little soundbite, we thought these stories are better than that. This work is worth more than just a little snippet here. So we stretched them out, and we really wanted the stories to be told. And I think this whole last few hours that we've done here is a real tribute, testimony to the strength of what individuals can do in their communities, to how they can bring change, to how they can take on even the most difficult problems and make things happen in a very positive way. At the same time, I think we really have to acknowledge that change occurs at an individual level, at a community level. It also has to occur at a systems level. And Michael Fratkin made reference to our crazy healthcare system. That's probably the nicest thing you can say about our healthcare system. So I'd actually like to start by asking each of our panelists just a little bit about what you think from a kind of a systems level, from the healthcare systems level, are the greatest problems that your community is facing, particularly in terms of gaining access to healthcare. And I'll start with you, Freddie. Of all the people that we've had today, I believe yours is the only state that did not accept the Medicaid expansion. And I know that and several people have alluded, Tammy alluded as well to and Jeanette to really the scarcity of resources in Mississippi. Could you talk a little bit about how difficult it is for people to get healthcare in your area, and because of Medicaid expansion, but other factors as well?
Here in the Mississippi Delta, it's very difficult for people to get health care. Many people lost their jobs during COVID-19. When they lost their job during COVID-19, it made things even more difficult. But not having health care here, people, they end up dying prematurely because they don't have health care. And when you don't have no insurance or no Medicaid or Medicare, I'm just sorry, doctors don't see you. I mean, they want a co-payment up front. And if you don't have that co-payment up front, and then you don't go in. So we see lots of people here dying prematurely because of the healthcare system. And unfortunately, the Mississippi didn't take the Medicaid expansion, and it caused a lot of hardship to lots of people who need this healthcare insurance. And we are just really struggling here in the Delta, and the resources are just so few. And when you working a job paying $8 an hour, $9 an hour, and then you had to pay child care, $50 a week or sometimes $100 a week, you don't have any money left to go to see a doctor. So really you just end up just wasting away, dying. And when you die, it's another problem because the family don't have no burial insurance, and it leaves the family at the mercy of the community to try to get their loved one buried. So it's very difficult here in the Delta.
Thank you. Chad, you're in New England, and I think everyone thinks of New England as being primarily, if not urban, at least heavily populated and, more sort of bigger areas and smaller areas. Can you talk a little bit about how difficult it can be for people to find resources in your area, and about you mentioned, driving to Dartmouth-Hitchcock is about 2 hours. How far do people have to go to get the healthcare they need? I know they have to go 22 miles on average to get food, but to a grocery store. But how about healthcare? How much of a problem is that?
I think every community is a little bit different. In the North Country, where our health center is located, we're kind of in the hub of the North Country, Littleton, New Hampshire. And if you're lucky enough to like live in the center area, ACHS, Amanusa Community Health Services, is a medical center home. So we have the luxury of offering primary care, oral health services, behavioral health services, and nutrition services from myself. So, you know, hopefully the services that we're proud to offer help out individuals looking for that all-inclusive care. Otherwise, I think care gets pretty fractionated around here. Like I said, if you see a specialist or you see multiple providers in different areas, you're going to be driving around like every other part of the country. A lot of parents and families have to decide whether they're going to make that extra, you know, trip, or they're going to go to work. A lot of the laborers around here, a lot of the jobs around our community are shift jobs, you know, where it's really hard to get that time off. I've talked to many people who, you know, are interested in getting together for a nutrition visit, but they don't have the time. They either are available after hours, after we close down, or on a Saturday where we have limited hours, and they're trying to get all of their household chores done, and, you know, trips to, you know, their errands and everything else. You know, I think it comes down to priorities as far as what you can afford on any given month. You know, so there's a big difference in the geography, even though New England and especially New Hampshire is a small state. I grew up in southern New Hampshire, and I moved up to the North Country a little over 20 years ago. And the cultural difference once you cross Concord, New Hampshire, you know, the state capital, and go up north, it's a huge cultural difference up here. Down south, there's in Manchester, Concord, there's public transportation. There's a lot more resources that are congregated in central areas. Up here, not so much. You know, there are clinics around. There's definitely resources, but people do have to drive quite a distance if they want to keep up with their healthcare in all those different ways.
Alma, I know that the Montana is kind of the opposite of New Hampshire in terms of scope and size. And you mentioned that even though it has been diminished, was diminished over the years, that the Crow Nation still occupies some 2 million acres. Talk to us a little bit about how people access healthcare in the Crow Nation. How do people find doctors? How do they get to see a specialist if they need one? I know when you talked about your daughter's illness, I think you had to go to Denver to get treatment at that point. So tell us a little bit about how people get healthcare in your nation.
Okay, so I mentioned in my documentary about the Indian Health Service, and yet it seems like, you know, people tend to think, well, you have that there, it's free, you can go. But again, you know, I mentioned the barriers, the quality of care. It just seems like it deals more with the kind of the basic care. So if you need to see a specialist, you're relying on the Indian Health Service to refer you out if you don't have insurance. And only the people that have Medicaid and Medicare are able to go elsewhere for their care. And many people desire to do that because of the mistrust, misdiagnoses that are prevalent. Unfortunately, as I had mentioned, people don't feel that, you know, comfortable going there if they're suspecting that something could be seriously wrong with their health. And so, you know, many people don't have that insurance. There's certain, you know, just a small number of people actually have private health insurance. So the majority are relying on just going into the Indian Health Service and seeing the doctor, hoping that this doctor will be thorough and concerned enough and care to take the extra tests and refer them to a specialist, and that's usually in Billings. Fortunately, Billings is not too far from the Crow Reservation. And so, but we have several communities. Some communities are a little bit further, but it's still just a little over an hour's drive. And so then that's helpful that you're usually sent to Billings, Montana, and there are specialists available there. And then some people actually are referred into Sheridan, Wyoming, which is about the same, an hour's drive, 45 minutes to an hour drive. But I wanted to share, I had mentioned in my documentary about that particular medical provider who was adopted by the two Crow families. Now this provider is one of the few trusted ones that has really developed a rapport and relationship with the Crow people, the trust that they have, the respect. He actually started a community health center here in Hardin, Montana, which is just on the border right there of the reservation. From the Crow Agency area where we have our main Indian Health Service clinic, it's just like 12 miles. And because he's seen, you might say, what was going on inside and how it seems like things should improve, but it never has. And that what could he do? What could he do to develop something that would be accessible and would provide that quality care that people need and deserve? And so now this is a community health center. It's called Bighorn Valley Community Health Center. It's just, in a short period of time, it has just grown. It's thriving. They actually just built a new clinic here in town. And many of our Crow people are receiving services here. But, of course, most of them do have, Medicaid or Medicare. But of course, if they go in and they don't have it, there's ways that they work with the patient, and it treats the wholeness of health. And that's very important. And so that's been a good thing here that has really been helpful in improving the care that our people need. So I think that's about what I like to share right now.
Thank you. Okay, well, that actually brings up my next question. All three of you are such strong testaments, and you emphasize so much how incredibly important it is to be a part of the community that you're serving. So, Freddie, why is, you belong to the church there, the local grocery stores. Why is it so important for you to be one of the community that you're reaching out to help?
Go back to the first question that we talked about with the healthcare system here in the Delta. When people don't have insurance, we, especially African American community, heavily are using the ER, the emergency room, to go there. And the emergency room is overwhelmed with a bunch of patients. And then if you go to an after-hour clinic with no insurance or Medicare, if you go there at 8 o'clock in the morning, you don't get out until maybe at 5 p.m. that afternoon when you're seen. And also transportation is a big problem. So if a person needs to go somewhere and don't have transportation and have to pay for transportation just to go 30 miles, they're paying $25 to $30 to $40 to go and see a medical provider. So we are struggling with lots of issues that's here in the Delta. And as I said earlier in my talk, you have people always coming to the Mississippi Delta, want to do research and want to collect data and want to collect information, but we are not leaving anything tangible for the people, and we're not empowering people to how to take care of themselves once the program is gone. So we got some big challenge here in the Delta.
Freddie, just to follow up on that, if someone wanted to come and do a program or to do something in your community, someone from the outside, what would you tell those people? How would you advise them as to what the right way to approach the community is, instead of just coming in and doing something and then picking up and leaving when the funding's gone?
But first, you just don't come in. First, you need to learn the community. You need to learn your community. You need to learn who are your movers and shakers in your community, and who those gatekeepers are in the community. Drive around and do windshield tours to see what resources are available, and talk to key leaders in the community and see what they have to say, because sometimes you can go into a community and you go in there, you're making an assumption that this might be the problem, but once you talk to the people, that's not the problem. There's other things they see as the problem. So you need to get to know the community, go to the different churches and identify yourself, who you are, talk to your political leaders and tell them who you are and what you're trying to do. And then ask them who are the gatekeepers in the community, who are actually making a difference. Who do people turn to in times of need? Who do people talk to when they need help? What doctors don't mind going above and beyond and not afraid to go to the community? And another thing, you need to go where the people are and not where you feel comfortable. So that's that. And just because you Black don't mean that I could go into a Black community and implement a project, because sometimes that might be the wrong person. So I would suggest that when you go into a community, go in there as a team, and we're going to change things and make things more diversity, is have a Black and white team to go in there and talk to the community as a whole.
Chad, you mentioned you came from Southern New Hampshire. Of course, in New England, if you've moved to a new town, you're still kind of a newcomer of 20 years after you get there. But talk to us a little bit about your community, and what would you advise someone who wanted to come in and do a program in your community? How do you gain that trust that's so essential?
I would just echo pretty much what Freddie said. You have to have those conversations with strategic partners in the community. I think what I'm doing in the community is starting to catch on, because I have so many key partnerships with trusted community stakeholders. We have a new food cooperative in town that a lot of community members really help to push the existence of this new supermarket in town, and partnering with them in their teaching kitchen really helps. And I think around in the North Country here, you have to put in your time. You know, there's a lot of mistrust and neophobia in general. If you're an outsider coming into the North Country, everyone knows everyone. I think like Alma was saying, you can't come in from, out of town and not be noticed and scrutinized. I've been lucky when I first moved up here from Southern New Hampshire, a Flatlander. I got involved with the Women, Infants, and Children's program as a nutritionist for the WIC program. I was the only male nutritionist in the state of New Hampshire working for the WIC program. So I got a lot of notoriety working for the program. I met, literally hundreds, if not thousands, of families in our service area. And I think to this day, when I transitioned away from working for the WIC program for 12 years and got into this public health nutrition job, I still see families that I was giving nutrition counseling for when they had 2-year-olds that are now, 15, 16 years old and driving a car. So I do have that familiar face that's been around in the community for a long time now. And I think that's part of the trust issue, is you just can't, come in and say you have a good idea, and when funding leaves, pack up shop. And that's another reason why I'm not a big fan of programs. I think it kind of defines a beginning and an end. I think what we need to work on is more of a continuum of building a culture of health, and learning from each other and having those conversations.
Alma, do you feel that people have a kind of wrong stereotype of Native Americans, that they come and they only see the poverty, or they only see the problems, when they don't really see the power and the resilience of your community? And if so, what would you tell people about that?
So I would say, and from my experience, I always say I am blessed with my research partner. I mentioned her in the documentary that Suzanne held from Montana State University, Bozeman. Her approach, and it was mentioned, I heard it today, is she was willing to listen. She humbled herself, and she's willing to ask someone from the community her approach, again, that approach is so important. You don't come in, with an idea that, this is what this community needs. You come in open, willing to listen, put aside even your credentials. Even though she's a PhD, one of our advisory board members couldn't have said it any better. She said, even though, she's a PhD, we sit around the table as equal. And for me, my experience has been in the area of community-based statistical research, as many of you are aware of, CBPR. And I think that's really, really, if it's applied appropriately, it can really be effective in working with a group of people such as us, as Native Americans. And so it was this, again, that approach, even though she was eligible to apply for this grant, she asked me first. She made a phone call and said, hey, there's this grant opportunity, but I want to ask you, do you think this will work amongst the Crow women? And the funny thing is, and I didn't really share this in the documentary, was that was actually my prayer. I had prayed in my heart to develop something specific to my own people, because I was traveling statewide for a while, and that was a couple of years, and that was it was good, but it was challenging. But yet through that, I gained the insight that not only the Crow women, but all of our Native women needed someone to take the time to talk with them. And so that's that approach, that humbleness, that willing to listen, having respect, knowing that, the people you're working with have expertise as well. And so that if we can come together respectfully and mutually and learn about each other's culture, then we can make something good happen.
Freddie, you mentioned the University of Southern Mississippi and your long-term partnership with them. Can you say a little bit about how connecting to the university as a major resource in your area has really strengthened your work and helped you in your mission?
Yes, the University of Southern Mississippi has done a big help here in the Delta with helping train community health workers. We have trained more than 1,000 community health workers. And one of the things that we saw that needed to take place was just not bringing this community program into the community, but let the people voice and express themselves. We feel as though as the problem is in the community, the solution is in the community. So we allow people to express themselves, and when people want to talk, you need to let them talk and you need to listen. And one of the things that we were faced with when we first started our community-based participatory research program, people was very concerned about when they heard research, again, they thought you got a school, a university come in here want to do research on African American, but you need somebody there to explain what is research, how research help, and don't try to make excuses for what happened with the Tuskegee situation. Talk about that research and talk about that was then, but this is now. So we got something in place called the IRB, which is the Internal Revenue Board, the review board who looks at any kind of research and before they give us the okay to go into a community and do anything. But we also got with the volunteers and we created a 501c3 nonprofit organization, because again, you see where peoples and organizations from all over is coming to rural community, want to collect data, want to go into the poor community, want to take photo pictures with the poor people, put these in the newspaper, put them, write articles on what's going on in rural communities, and they never leave anything tangible. So it was important to us that we not only just go in there and do research and do health skills, life skills to help people to change themselves and make their life better, but to have something that's, again, like I said earlier, just owned and operated by the community. So that was done with the 501c3 nonprofit foundation that was created by the volunteers, the community health worker. The university helped with that project by helping to identify resources. And whenever a grant is written, the university is the academic piece and the community is the engine piece. So it's a shared partnership. So university get a portion of the money through the grant and also put monies in the foundation for the volunteers or the community to have to operate within their community.
Freddie, I think all of you, it's really important that connection between you as individuals to your communities, to maybe a research base or to a partner that brings other resources, but really all keeping it very grounded in the community and listening to the people in that community. We have a little time left here. So Chad, I know everybody understands that, you know, if you eat healthy, you're healthier. Can you talk a little bit about why access to food insecurity is such a major component of a healthy community, of a healthy individuals?
Sure. You know, food insecurity is definitely a big issue. There are definitely a fair share of families here that rely on food banks, services such as SNAP program and WIC and other things like that, to be able to make ends meet. And I think, you know, we need to, you know, address food insecurity with as many programs and resources as possible. I try to direct people to, you know, all kinds of resources in our community as far as, you know, everything from food banks to the WIC program to state benefits to even the local community programs that are going on at, you know, the local farmers market where you can buy, you know, $40 worth of produce for $20 using a Granite State Market Match token, you know, things like that. But food insecurity is one thing. I think what, especially up here and a lot of other places, lack is consumer insecurity is a big issue. You know, like I said before, I think there's a gap between providing nutrition and nutrition education and medical education and expecting patients and community members to know exactly what to go and do. There's a lack of an action step there that I think needs to be addressed, and I think that's a big part of the food insecurity piece that leads to nutrition insecurity is that, you know, if you don't have the cooking resources, or if you feel like you don't have the time to cook, those are also part of the food insecurity problem where, you know, in reality, I think from what I've seen, to eat healthier, it costs about $1.50 extra a day. And, you know, with a family of, you know, that's about $500 extra a year per person to eat healthier. With a family of 6, that becomes a very tedious thing to try to keep up with. But also, you know, how you spend those money dollars counts for something. And I think what we're seeing across the country, you know, especially here, is resources that really help out from a younger age. Things like home economics was something that I had to take in middle school, and none of my children have that in their school right now. That's a big gap where people are more and more dependent on strangers providing their food for them because they don't know how to cook lentils and beans and make them palatable for their family. You know, cabbage is a really cheap vegetable and available all year round, but no one's going to eat it if you don't know what the heck to do with it once you get it in your kitchen. So I think food insecurity and consumer insecurity are both big issues.
Thank you. So I really want to open this up for questions, but I'd like to finish by asking each of you, and we'll start with Alma. If you could do one thing, change one thing, if you could really make one great improvement for the health of your community, what would it be?
Again, you know, kind of, I mean, I'm talking, I mean, I know, you know, getting people and accessing healthcare is really important, but I believe what we're doing right now and what the area we're heading to is, in the midst of what we've done in research and the experience we've had in working with people one-on-one, what's really come out strongly is how much our people need inner healing. So the area of emotional and mental wellness, that's the area where we're going into. And like, we actually just started some phone interviews. It's kind of starting out as kind of a small pilot project, you might say. We were going to meet with people one-on-one, but because of the pandemic, you know, it's turned into phone interviews. I've actually done about 4 of those interviews so far, and listening to people share from their heart. And the question we ask them is, the first one is open-ended, and what I'm asking our people here is, so could you share with me what's been shared with you by your parents or other elders about how we as Crow people take care of our health and our well-being? And, you know, it's just opened up. Well, I'm listening to stories, you know, that were passed down from generations, and how we use the natural herbs and how we maintain balance. And so it's powerful. So again, I want to see, you know, that before someone can take care of the outside, they need to heal within. And again, it still goes back to that historical trauma. It still stems back to that, but we can overcome, we can heal, and we can forgive. We have to. Forgiveness is freedom for us, and that we have our ways here, our cultural values, and I mentioned our spirituality, and within spirituality is forgiveness. And so I want to see our people heal, inner healing. Right now, with this pandemic, we have had a lot of loss. In fact, over the weekend, 4 Crow Indian people passed from this COVID virus, this COVID-19 virus. It's making a very significant negative impact in our community. And so grief, multiple grief. That's one area that our people struggle with, because our value is, we value life. Life is more valuable than anything else. Anything, money, we value each other. And this is something I've shared before, like every day is a good day in the Crow language. We say, the only day you have a bad day is when you lose somebody you love. And so with that, we have been impacted. And when one person passed away in our community, it affects us because we are close. We are close in kinship. We mourn with them. We pray with them, and we are impacted. So I want to see inner healing, overcoming, forgiving, and being more balanced and mentally and emotionally. And we have our own resources. But like I said, it seems like when we're so oppressed, we don't see what we have. We don't realize what we're going through. Sometimes we need someone from the outside to come and work with us so we can together work and utilize our own strengths to heal ourselves.
Thank you, Alma. Chad, what would you like to change? What would make a difference in your community?
Well, I think there's a lot of things that need to change, but I think primarily, you know, people in my position, providers, they really need to work on engaging people where they're at. I'm not sure how many of our how many people online here know of motivational interviewing and open-ended questions like Alma was just referring to. I think that's where change needs to occur on that individual basis. Every chance that we get to meet with a patient or even a fellow community member, how are we going to influence them to be, you know, a little bit better with their diet, a little bit better with their habits, and how can we get that ingrained into our culture as like a first tier type of thing. So I really think, you know, learning the art of conversation with patients and with each other is really important part, to ask those open-ended questions, to offer education when education is asked for, or you know, not just because we think that a patient needs it. I think we need to meet them where they're at, and if, you know, we can't expect everyone to eat broccoli and quinoa who's might be drinking 12 Mountain Dews a day, the first thing is to talk to them about, well, how do you feel about your Mountain Dew habit? Maybe that's not where they want to start. Maybe they want to start with something else. I think that's what we need to focus on, and trying to have a little bit more time for conversations instead of trying to have a patriarchal relationship with patients where I'm the provider, I have the credential, this is what you should be doing. I'd like to see that whole essence of the conversation change.
Thank you. Freddie, we will end with you before we, I think, have time for a few questions. What would you like to change in your community? I know maybe a lot of things, but one thing that would really make a difference, would really make you rise up.
I hope I don't step on toes when I say this here, but
no, there are no toes here, Freddie.
Sometimes you have to be realistic with stuff. And in my community here in the Mississippi Delta, I really think if we could just change, and I know this is something that God himself is going to have to do, if we could just change race disparity. Race disparity has really hurt our country, the state, and Mississippi. If everybody just had love in their heart and just not look at me as a African American when I walk into that office, or when I walk into that bank trying to get a loan, and just see a person who are trying to better him or herself and help that person, that would really be a big change. And I think everything else would just fall in place. I think race is the combination to everything that goes on when it comes to disparities, when it comes to health disparity, when it comes to community patient engagement. That's the problem, and people don't want to address that because a lot of times they're afraid what the next person might say. And then when a person crosses over and try to do what's right, you're ostracized by people who look like you. I've seen Black people ostracized, like myself, when I try to cross over and work with Republican and Democrat parties for change. And I've seen whites there who say they want to help, but they're afraid to step out. They're afraid to step outside of that boat, as Peter did. Patient engagement, we need to have patients at the table from all levels. You got middle class, you got upper class, and you got the lower class. And many times when I'm at these meetings, I see the patient at the table, but what might affect you as a upper class is different from what might affect a person who's lower class. And those people need to be at the table. I can't be the voice for the voices all the time. I need to have that person there who's been affected by that problem at that table to help with identifying the problem and develop a solution and coming up with action plan. I think when any organization come into a community, before they lead that community, they need to assist the community with creating an action plan, a community action plan. And every action plan that's implemented you're gonna need resources. You need financial resources. Stop putting all the money at the universities and you're paying all these indirect costs, but put monies into the community health centers, into the 501c3 nonprofit organization. And to me, that would help with hope. People need to have hope. And in order to have hope, we need to start leaving something tangible in every community that we go into. We need to leave something tangible. We need to leave something tangible that's owned and operated by the people. And that relationship need to be ongoing, not just a one-time, not 3 years, not 5 years, but it need to be an ongoing partnership.
Are there any changes you would recommend to the way certain benefits, SNAP, EBT, WIC, et cetera, work so that they were better for users?
Chad,
I
you want to pick that one?
Yeah, I mean, it's I don't know. The SNAP program is kind of complicated. I think WIC has made some improvements. When I first started working for WIC, we used these printed out vouchers that could be used at grocery stores. Now they use a debit card type of system. I think a lot of a lot of assistant programs out there. There's a sense of pride and shame of using those, and I think we need to break down the barrier of that. I think there also needs to be a component with bigger programs such as SNAP. I know they do have resources out there, but I think, you know, a bigger part of receiving those benefits should be a little bit of a how-to, you know, incorporated into it, as far as, you know, maybe, I don't know, maybe a regular online cooking virtual class that you participate in to continue to get those benefits. So, you know, at least you're exposed to, you know, different cooking methods and different preparation methods. And I think that could really help people use those benefits. And I think that's what the bottom line is, you know, I see a lot of people that, you know, apply for SNAP benefits and tell me, oh, I was only eligible for $20 a month, so that's not worth it. I think every little bit that you can get for assistance is worth it if you know how to stretch that money. Right across the street from me, I mentioned a couple of times the food cooperative in town. They have a great local program. If you receive SNAP benefits, you just show them your SNAP card and you can get 50% off all your produce at this grocery store, and it's great local produce when we are growing it in New Hampshire. But you know, a family can walk in there with, you know, their $20 monthly allotment of SNAP and get $40 worth of fresh, frozen, or canned produce. And, you know, to me, that it means a big difference if you have a large family of whether you're going to feed them healthy or not. So I think some of those things need to be taken in consideration.
Freddie or Alma, do you want to add anything to that about the programs, the availability of benefits, or how people access benefits?
I think Chad did a good job explaining.
What I would add is, I know with one of our last research project, we kind of have some information that we shared with people about eating healthier. These are people that have a chronic illness, and you know, we're trying to help them improve their self-care. And so one of the big areas is nutrition, and you know, many of our people are diabetic. And so I just kind of want to just, I guess, reiterate what Chad has already shared that really kind of struck me. It's so true, is yes, you can provide that nutrition education, but there's like a gap. What's that missing step? How do you kind of really help people? Okay, I've got this vegetable here now, or this zucchini. How can I make a meal out of this? Or what recipe? How can I then make this healthy food taste good? And so teaching them about, you know, how to cook. And that was something that we actually discussed in our meetings about as we talk about nutrition and the importance of it. And so really, I mean, it's kind of always been my model that, you know, I don't think eating healthier should be that expensive. And you know, so I'm really thankful that it was kind of brought out about, you know, eating healthy. Really, it should not be that expensive. And so I'm really just thinking about many of our people here, you know, the poverty level. Many of our people are SNAP recipients, and WIC, you know, for some of our younger moms, and that they could really benefit. And we've tried to do some things. I know there's an extension office that used to hold those nutrition education classes that young women would attend, and you know, they're learning how to, you know, recipes and what they can cook, you know, in a healthier meal. And so I think I'd like to really see some more of that, and that could really benefit people, and to just kind of remove that mentality that it costs so much to eat healthier. We've got to overcome that.
And
Thank you.
sometimes people,
One more question, or Gwen, do you want to bring us home? All right, one more question. Jamie, do we have another question?
I'm going.
We do. We have
Oh, you're
another.
going?
We do have
You can go
another
to
more
question.
question.
325.
Okay.
All right.
Go ahead,
So
Jamie.
from Lisa Stewart. Hi, Lisa. How is patient engagement supporting change in your communities? And I know that Freddie just recently touched about patient engagement in Mississippi, but perhaps Alma and Chad may want to weigh in a little bit on that.
Yeah, I think
Uh,
Freddie's statement was really strong, but Chad, did you want to talk about patient engagement in your community?
Yeah, I mean, like, you know, what Dr. Fratkin said, we have to stop referring to people as patients, they're community members. And one of the best ways to get out and engage with patients is out in the community where they, you know, live, work, and breathe and sleep. Getting your door into the senior centers. I've gone to all of the senior centers in our service area that I can find. Sending out letters to elementary and middle schools and high schools and trying to either be a guest speaker or, you know, try to create some initiative within the school walls, you know, maybe be part of a wellness committee, you know, really getting out there and trudging out where, you know, where people work. So you know, I think that's a big part of engagement, because a lot of times patients aren't necessarily going to come to the healthcare center every time they have a question or need something. We live in that patient role. If you consider how many hours there are in an average life year, I don't really know off the top of my head, you can imagine how many of those hours every year you spend inside that patient role. You know, it's probably less than a fraction of 1%. The rest of that pie graph of our, you know, yearly hours is spent at work, in home, you know, going to church, doing our errands, you know, trying to go to events at our children's school, sporting events. Those are the places where, you know, people need to be engaged at, and that's part of what we're trying to do right now and trying to get out there. COVID has really been a downer as far as that goes, but you know, there are multiple, especially in the summer and the nice weather months here in New England, there's lots of events to get out there and really make an appearance and try to, you know, gather that momentum of, even if I can get, you know, one go-to recipe out there that people can kind of add to their repertoire, you're doing a good job. And I think that's, you know, you have to celebrate the small, you have to celebrate the small challenges, the small successes. I mean, it's not always going to be a big success. You got to like really look at, you know, if this person said they made that recipe that we went over, you know, twice this month, that's a good step in the right direction, I think.
Good. Alma, how about your community in terms of patient engagement?
So for us, we were able to, like I mentioned, you know, Indian Health Service and the barriers, but yet, you know, we've come about it in a way, what can we do to work with Indian Health Service so that things could improve? And so that was the perspective that Messengers has had and continues to have. And so we actually have done some work, taken steps to work directly with medical providers there. And we partner them up with one of our messengers, and especially those that just come in. See, there's providers that come and go. And that's where it really makes it difficult for people to our Crow people to really develop that relationship and that rapport, because they find a provider that they really do feel that is, you know, treating them, you know, with that whole, you know, dignity and respect that we talked about, and love and trust, and then they leave. And so then that makes it very challenging for people too. So we began to just allow that kind of a relationship between a messenger and a provider to go out in the community, to invite this provider in the community, especially the ones that have just begun, welcome them. And we've developed a couple of videos. One of them is titled "Medical People Take Good Care of Us," and that's how you say it in the Crow language. And then we developed a second video, Crow Voices for Health, and that it's mutual. That partnership is mutual, and that's what we've kind of been stressing to in our outreach, that it has to be a mutual partnership. It's, you know, and that you don't go to Indian Health Service to get well, as one provider mentioned, and that that you have to do your part. Outside of that clinic, you take care of yourself too. You do your part, and then you come, and that relationship is there. And people just want somebody that cares. And so it's gotten some attention. We continue to work right now with our last research project. We worked with people with chronic illnesses, and provided them with tools, helping them to communicate better, asking questions. What can we do to encourage them to be able to ask questions, to feel comfortable? And so it's all those things that we've began, and we continue, so that there can be improvement in that relationship, and it has to be mutual.
Thank you. And I want to thank all of our panelists for, first of all, for the
Chris-
amount of time they gave to us in putting the documentaries together, particularly in the COVID era, where it's not easy to do any of those kinds of things. And you guys were so incredibly cooperative, and you brought so much to the table. And then I thank you for being here today, and for the wonderful discussion that you provided about your communities, and what the different kinds of cultural and things that we need to understand and think about when we put our programs together.